Who else can record? So we will keep record of all this. I will record here, but I would like somebody else also to do that.
I can do that if I'm allowed.
Who is that?
This is Atif.
Atif, okay, go ahead, Atif, and record, because we would like to keep record of all this, so later we can like make excerpts of them, not necessarily. Okay, I will.
Okay, I have sent a request for you to.
Yeah, I have approved. I approved your request already.
Thank you.
Okay. Also, we welcome Professor Iman Qasim, the General Secretary of the African Academy of Neurology from Tunisia. Welcome, Iman. We are in this session today really honored by the presence of high esteemed senior people to discuss with the juniors the cases for today. Professor Ammar, do you hear me, Ammar?
Thank you for the invitation, Professor Ushaykh.
Okay, you can say something, Iman, to the group, because we have, I don't know, maybe you are 30 attendees or something of trainees in neurology. Iman, we will appreciate a word from you.
Hi, Ushaykh. Assalamu alaikum.
Assalamu alaikum, Professor Tahir. I will let Professor Tahir speaking.
No. You can say something, no problem. Ammar, I apologize. Because Iman is the General Secretary of African Academy, and we have Professor Athenes Meligo, the Vice President also. And we just hear a word from them, encouragement to the trainees and to this activity, which we hope it will also bring people together, not only discuss cases and training, but also to know each other. So Iman Qasim and Athenes Meligo from the board of the African Academy of Neurology, most welcome.
Thank you, Professor Ushaykh. Thank you and congratulations for this initiative for the young trainees to discuss cases. I think the participants are from Africa only, or from
anywhere. Please mute yourself. We can hear people. Okay, please mute yourself if you are not allowed talking. Please mute yourself. Athenes Meligo. Athenes Meligo, do you hear me? You don't. Anyway, as time goes on, we will, because we have this technical problem. Professor Ammar, the floor is yours. I apologize for the others. Please mute yourself if you are not talking. Thank you. Ammar.
Welcome all for this session. Without losing much of time, the first presentation would be by Dr. Atif.
This is a security message. If you see something that doesn't look right, speak to staff or text the British Transport Police on 61016. We'll sort it. See it, say it, sorted. 24-hour CCTV recording is in operation at this station for the purpose of security and safety management.
Dr. Atif, now you can start presenting your case.
And an underground service too.
But you did not introduce Dr. Atif, ya Ammar. Atif is a neurology registrar from St. George's Hospital in London.
Yes, I'm going
Thanks
to.
everyone. Is my screen clear for everyone?
Yes, it's clear.
Hello, can you see my screen?
Yes, it is clear.
Okay. Good evening, everyone, and thank you for joining me today. My name is Dr. Atif Al-Amin, and I am neurology trainee registrar, St. George's University Hospital in London. And the title of today's talk, a headache that wasn't just a headache, sets the stage for case that at the first glance appear to be.
And if you see something that doesn't look right, speak to staff.
Can you please mute yourself all? Can you all mute yourself, please?
Sorry.
Continue, Dr. Atif.
Okay. So this presentation will walk you through the clinical reasoning, investigative workup, and multidisciplinary decision-making process that lead to unexpected diagnosis. During my presentation, I will be pausing at key points for interactive discussion and your input. So please feel free to share your thoughts as we go. So the patient snapshot. Let me begin with introducing the patient. This is a lady who is 28-year-old, right-handed woman with no known past medical history. She migrated from Kenya to the UK fairly recently in October 2023 and has since been working as a healthcare assistant.
Platform 1 for the 1835 London Underground service to Richmond.
She doesn't smoke and she drinks alcohol occasionally and denies any recreational drug use. There is no family history of neurological problems. She was admitted on the 12th of February 2025 under the care of the neurosurgical team following referral for evaluation of severe headache and some finding on the imaging, which we are going to discuss. History of the present illness. Now let's talk about the history of her presenting complaint in more details. So this was a new headache for her. She had no prior history of headache at all. And the headache started about 2 weeks before admission, described as bifrontal and involving the back of the head. It developed gradually, but got significantly worse over time, eventually becoming excruciating. She rated the severity of headache as 10 out of 10 and was crying in pain. She first presented to her GP twice in the week before admission and was treated empirically with codeine and sumatriptan, but neither helped. So she later went to the emergency department where she received an IV paracetamol,
37
which
London Underground service to Upminster.
So the paracetamol gave her some relief, but at the time she returned home, the headache recurred and she was unable to sleep due to intensity. So overall, we have a new escalating headache resistant to simple analgesics and migraine treatment and distressing enough to interrupt sleep, features that should raise red flag and prompt urgent investigation.
Dr.
Yes. Hello, Prof. Hello. Are you hearing me, Prof. Ammar?
Yes, we are hearing you.
Prof. Ammar, do you want to say anything?
I think Professor Ammar wanted to stop you here and to ask people to participate. Do you hear my interruption?
Yes, I'm hearing you.
I think Atif, you should not give everything. You just stop here, and we would like to hear from the others to talk about the differential diagnosis. When you give a differential, please give reasoning why you think of so, and you don't give the examination now. Okay? Ammar,
Okay.
sorry for interrupting. I think the technical problems will be playing on me and Ammar today. So don't go. Just keep where you are. Okay?
Okay.
So anyone who would like to be heard, you can raise your hand or unmute yourself gently. We don't want two people to speak at the same time. Ammar, are you back on the stage?
Yes, I am back.
Okay. I leave it for you.
Yes, we'd expect from the history, you have to flash all the possible causes, having in mind the different causes of headaches. So one would expect the audience to participate by asking more questions. And by asking more questions, we'll be in a position to offer a possible differential diagnosis based on history before we proceed to. Any more questions?
Welcome to the New England Journal of Medicine. I'm Dr. Lisa Johnson.
What the cause might be? Yes.
Yes, if you allow me, Dr. Atif, photophobia with headache in a young female, I will think of migraine. If it is recurrent and throbbing, if there is, I would like to ask about if there is any phonophobia also. This is the first thing that come to my mind.
Okay.
Okay, this patient has come recently from Kenya, presented with this headache for 2 weeks, and it was progressive, and she has photophobia. I may think of infectious disease. I would like to ask about fever in this patient first.
Any red flag?
Okay.
Any red flag, Atif? Any red flag?
There is many red flags as you see here, especially with pulsatile tinnitus for the past week and the neck stiffness also.
I mean, other than this one, lot of symptoms.
The other red flag, I think, the severity of headache itself, and the headache was not responding to conventional analgesia, like the paracetamol and the conventional migraine treatment. This is also another red flag, I think. And she's someone who's not known to have any headache or previous migraine history, although a migraine can start at any time, but she's not someone who's having any headache, and she was quite well until 2 weeks before admission.
What about drug history? Is she having?
She's not having any previous medical problems, and she's not on any long-term medication, and she's not having any medication allergies.
Not on OCP.
No, she's not on any oral contraceptives.
If any change in her weight, did she build up her weight recently?
No. She's someone who is not having high body mass index, really, and she's not gaining any weight recently.
Did she have any
question of fever? One of the somebody was asking about fever, Western condition of fever coming from Africa.
Bro Ammar, صوتك شوية your voice is a bit away. I'm not sure.
Ammar asked already if there is history of fever, but you already gave the answer. It is you have written no fever or temperature.
Yeah, and no
recent. But the last point, Atif, I just comment in the way you are presenting. Don't give the answers very quickly. Let people ask like 3, 4, 5 questions, and then you write down this, and then you respond to them. Maybe the questions will be related, and it might be more informative if you see how people are thinking rather than you give the information very quickly. And you said no recent travel, but you said she came from Kenya 2 weeks ago. So when we'll ask you why you say
no. I'm sorry. She came to the UK about 1.5 years ago.
Okay, so
late 2023, and
okay, that's what a bit misleading. So again, we use this forum to teach you also how to present, but rather than just give all the information from the outset, we would like you just keep where you are. We would like now people to give us differential diagnosis and to give reasoning. If you say infection, why you are saying? If you say migraine, like what Mahmoud said, because of this, I think of this. So we'd like reasoning for the differential, not just to give us a list of the differential of a headache.
Okay.
Okay.
So do you allow me to give the differential?
No,
not you.
Atif, you are not allowed to say anything.
Okay, that's fine.
Atif, you just wait. Let Professor Ammar squeeze people on the differential.
Yes, please.
Atif, can you verify more about the vomiting, the nature of vomiting? Is it projectile vomiting?
It is early morning vomiting rather than projectile vomiting. It is early morning. She woke up with the vomiting and the headache.
In the urinary variation, for example, the headache is worse at the end of the day or the morning, early morning headache.
No diurnal variation.
Atif, don't answer. Don't respond one-to-one. Don't respond one-to-one. Let people storm. 2-3 people ask questions. We are also training you on not to do one-to-one. We are training you to get 3-4 questions and then you respond. Let people ask more questions.
Okay.
Dr. Atif, you mentioned in the slide that there is no visual disturbance, but specifically, did you ask her if she have got any transient visual obscurations specifically?
Dr. Mahmoud, why are you asking about this?
Because I'm thinking of idiopathic intracranial hypertension. Sometimes, if you ask the patient that do you have any visual problem, she will say no. But if you ask her specifically, do you see black? Some occasions when you stand from sitting position, she might respond with yes.
So now you are fishing for the most different.
Yes, I would like to ask about signs of symptoms of papilledema. Symptoms of papilledema.
We let us say symptoms of increased blood pressure because papilledema is a sign. Okay.
Yes.
Somebody asked about diurnal variation of the headache and the vomiting. Somebody was asking about diurnal variation of the headaches. What is the significance of if this headache occurs in early morning?
Early morning headache with projectile vomiting, that indicates that the patient had a high ICP. So, for example, I'm thinking about cerebral pathology in the brain, for example, CVST, any specific bile lesion, something like that. But the head.
So sensibly, you are looking for causes of an increase in the blood pressure from whatsoever cause.
Yes.
Okay. Any more questions?
I would like to ask about this tinnitus. Is it accompanied by any hearing problems, or are there any dysarthria, dysphagia? I'm asking about anyhow problems in the jugular area, jugular foramen, because I think for versatile tinnitus is rather has a limited a limited differential, like increased cardiac pressure and maybe glomus jugular tumor and so on.
So you are asking about tinnitus, perhaps it might be related to this headache. Might be related to the etiology of the headache. What is the most? Tinnitus is said to be a symptom of what problem is associated with tinnitus, especially in this patient having headache with projectile vomiting early morning.
CVST and IIH.
Please don't use abbreviations which we know among ourselves as Sudanese, but there are other people who are not Sudanese and they don't use these funny abbreviations. So what is CST?
Cerebral venous sinus thrombosis.
Okay, that's better.
And also as IIH also can cause.
Yes.
What is IIH?
Idiopathic intracranial hypertension.
Better say that like. Okay, may I ask one question if Ammar allows me?
Yes, please.
Any postural effect on the headache? Like, is it getting worse in certain position, or with coughing or sneezing. Sometimes patients get worse if they are lying flat, or they get worse if they sit or stand up. Is there any hint like this?
Sorry, Prof. As you see in the middle of this slide, there is no postural worsening of headache.
Okay, I saw the point out, but I wanted to bring that to their attention as well, because it is not only raised intracranial pressure; it might be low intracranial pressure as well. Tinnitus could be sign of low intracranial pressure. If somebody is having like post-lumbar puncture headache or idiopathic intracranial hypotension, if they sit up, they get the tinnitus, and then if they lie flat, the tinnitus goes away because they are pulling on the acoustic structures, and also they are pulling on the meninges and on the cranial nerves. So not only raised intracranial pressure cause postural problem, but low intracranial pressure, which we should not be forgotten as well, might cause this. Okay.
Any more suggestions or questions before we leave Dr. Atif to respond? Now proceed, Dr. Atif. Would you like to respond to all these questions and queries?
Yes, of
before
course.
you proceed, did the patient have any loss of weight, Atif?
No, she didn't mention any loss of weight.
Okay.
So in response to your queries, the differential diagnosis we put for this lady, as Mahmoud and the rest of my colleagues mentioned, the first thing was, is it idiopathic intracranial hypertension? Is it cerebral venous sinus thrombosis? For example, idiopathic intracranial hypertension, because it's common in young women, especially with the pulsatile tinnitus and headache and vomiting and photophobia, but usually has visual symptoms, which is not here. Cerebral venous sinus thrombosis, classic for headache and pulsatile tinnitus and vomiting, and risk factors, as you know, hormonal contraception, which is not on, dehydration, prosthrombotic states. And her migrant status, consider we also we need to consider other differential like infection or nutritional deficiencies. As her headache is very severe, we also need to consider differential of headache like thunderclap headache, which is the most common cause, that is subarachnoid hemorrhage. It is atypical here because the onset of headache was not reaching maximum severity from the first minute or the first 5 minutes. Other differential we put was meningitis, or which could be viral, TB, or partially treated bacterial, especially with she's not having neck stiffness or photophobia or nausea, but no fever, and she's a traveler.
But Dr. Atif, you did mention that the patient has got neck stiffness.
Sorry, she had neck stiffness and photophobia. I meant, yeah, this is why we put meningitis as differential.
Yes.
And then we put a possibility of posterior fossa mass lesion because she's coming with feature of raised intracranial pressure with this severe headache and vomiting and neck stiffness. And last, at the bottom of the list, we put possibility of refractory migraine or status migrainosus, as the headache was severe and unresponding to triptan and codeine. And although codeine is not a good medication for the migraine, but she was given by the GP. And she's not having any clear prior history of migraine, so migraine itself was less likely. Shall we proceed to the next slide?
No, Dr. Atif.
Okay.
I think considering all these factors, this is a story of a young lady who developed severe headache of short duration, which is progressively worsening. From this long list of differential diagnoses, what are the two most likely causes of this problem? Let us agree that this is a headache of increased cranial pressure. We all agree about that. It's not migraine, it's not tension headache, it's not cluster headache. So this is a headache, a severe headache, an acute headache of short duration. Possibly, most likely, it is due to increased intercranial pressure. From this long list of differential diagnoses you did mention, what are the two most likely causes of this headache? Because having reached this differential diagnosis, we'll go to examination, having in mind all these, the most likely differential diagnosis. And then when you go there to look, we look for signs, not try to finding signs. Okay?
Yeah, thank you. So yeah, I think the top two differential diagnosis will be either idiopathic intracranial hypertension with the feature of rising intracranial pressure, or any possibility of space occupying lesion, and other differential will be venous sinus thrombosis, as she's coming with feature of headache of raising the intracranial pressure, although other feature was not there, like seizure and other feature of severe venous sinus thrombosis. So this is the top three differential diagnosis, I think, along with the possibility of infection like meningitis or encephalitis with the neck stiffness. This will be at the bottom because no fever also, although encephalitis can come without a fever.
Okay, if you allow me, Ammar, to comment also.
Yes, you would like to comment.
Again, this training for you, Atif. Atif, if I am examining you for the final exit in CCST, I will not allow you to answer this way, because the examiner asks you give the most important two causes, and you are comfortably discussing three causes. Why you are doing that?
I'm sorry about that.
So next, when you come for the assessment, your annual assessment, or in the final exam, if they ask you to give two causes, don't give three.
Okay.
Thank you.
Thank you.
Yes, proceed, Dr. Atif.
So we spoke about the possible differential diagnosis. Let's have a bit of break. If people are football fan. Okay.
Mbappe,
Yes. Okay. So clinical examination. On examination, she was alert with GCS of 15.
Dr. Atif.
Yes.
Sorry to interrupt. Don't mention the examiners. Ask the audience, what are the expected findings on examiners? Let the audience comment first. Let the audience suggest the possible findings on examiners, which can explain the problem of the patient. Before you mention the findings yourself, let the audience suggest expected findings on examiners in such patients. And then you comment positively or negatively when anyone of the audience suggested this sign or so and so, and not that sign, and so on and so on.
Okay, it is open for the audience.
Yes, if you allow me, Dr. Atif, to be a safe doctor, I should differentiate between primary and secondary headache by examining the fundus, looking for any papilledema. Also, other causes of raised intracranial pressure like bilateral or unilateral 6 cranial nerve palsy.
Yes. If you start.
Yes, also I will examine for any SVT.
Yeah, Dr. Mahmoud. If we start positively on the higher function first, in such patients, this patient Glasgow Coma scale is about 8. So let us start sensibly. Let us start sensibly. highlighting points in the higher functions, expected findings when we assess the higher functions. Then we proceed to the cranial nerves. Expected findings on the cranial nerves, referring back to the story. And then we proceed systematically. Yes? Expected findings on higher functions in such patients.
So we'll examine for the consciousness level,
Yes.
definitely, and orientation to find pleasant
Yes.
person. And I will, while I'm talking to the patient, I will assess his speech. Is there any dysphasia or dysarthria? Also, I will assess the memory by giving him 3 objects. Then I will proceed to the cranial nerves. Specifically, I will concentrate on the second cranial nerve, fundus examination for any papilledema or any visual field defect. Also, I will examine the other cranial nerve, 6th cranial nerve, if there is any lateral eye duction problem. I will assess also the swallowing, looking for the bulbar function also. And I will examine the limbs for any asymmetry in reflexes or in
Hello.
Yes.
Hello.
I think Ammar, we have to now to try to go faster because we are already late and some people might get bored. So is this teaching you the technique of presentation and how we are trying to bring you up to the point. Whenever you say something, you should have reason for it. When you give reason, and then you build up the reasoning towards the differential, then what are you expecting on examination? And we will see what you found already. Because you have shot the slide with the findings. Again, let the one who's chairing session or in a conference, if they ask you to stop or whatever, they might have reasons. So they say stop, you stop, and then you carry on. And I like also Atif going back to allow Professor Ammar to put this important point. So we are talking about not only the clinical, also on the technical presentation, and to make you sharp, appealing presenters as well to international front. We are not just training you just to present in your ward or in your local clinical meeting. We are sharpening you to go on the stage on international as well. So I will comment on the technical side. Ammar is chairing the whole thing. So I will leave Ammar to carry on.
Yeah, I think as Sheikh has mentioned, because we would not like the presenter to disclose the findings on examination because the story would become obvious. So we will ask the audience about the expected finding on the examination, and they have to be very focused. Having this story, you have to look for certain signs. You are not going to go to list a very long list from them, but you are going to be focused, telling about the positive finding, referring to the history and the differential numbers. But I think Atif, now you can proceed. What are the findings on examination, Atif?
Okay. So on examination, she was alert with a GCS of 15, which indicate no impairment in consciousness, which is an important point, I think, when considering raising intracranial pressure. She is also having 6 cranial nerve abducent palsy and papilledema fundoscopy, and these, as we all know, are classic signs of raised intracranial pressure. And the 6th cranial nerve, particularly vulnerable due to its long intracranial course, I think, and susceptibility to stretch or compression from elevated intracranial pressure. As a presence, I think, of papilledema also corroborates this. Papilledema is the hallmark of raised intracranial pressure and alert us to the need to avoid lumbar puncture in this case, I think, until imaging rule out mass effect or obstruction. Importantly, there was no focal limb deficit, and the rest of the neurological examination was unremarkable. which again, this will also argue against a large space occupying lesion to the eloquent cortex or significant brain stem involvement. So in summary, this examination supports a syndrome of intracranial hypertension, possibly secondary to structural or vascular process rather than diffuse encephalopathy or infection.
Any more suggestions? So would you like to ask the audience about how to investigate this patient?
Yeah, they are welcome to
suggest investigation. This is a patient of this is a patient who presented with headache, having signs of increased intracranial pressure, having signs of increased intracranial pressure without no focal lesions.
After routine investigations, the CBC, RFT, TRB, ASR, then we need to do MRI, brain, MRV. MRI is contrast, and MRV is to exclude the cerebral venous thrombosis.
Okay, before the MRI?
CT, CTA, CT brain, CT bionography, CT angiography. If it's not available, the MRI is the standard or the investigation of choice with contrast, because if I'm thinking about, for example, infection or venous thrombosis, it's of good value. But if not available, CT brain, CT venography, CT angiography also can be done. Before that, the routine investigation.
So Dr. Onzar, you suggested CT angio, an MRI, an MRA. Perhaps you are targeting CBT, cerebral sinus thrombosis. Any other suggestion? Just by doing a CT? Just by doing a CT with contrast. Can you think of any other suggestion?
Yeah, any specific lesions can enhance also ABM, for example, after reverse malformations. Also,
you mentioned enhancing lesions. Could you ever think of any enhancing lesion, perhaps that might have led to increase in intracranial pressure and papilledema?
Yes, especially the fossa masses.
Yes.
If it is malignant, they can enhance. Grade 3 and 4 specific lesion can enhance. So I'm looking for that.
So but this is one possibility. Any other possibilities of an enhancing lesion, which could be detected by CT without proceeding to angio? Just CT with contrast. You did mention posterior fossa tube. Anything else? You are right. You mentioned CT angio and MRI and MRA. You are right in trying to find out cerebral venous sinus thrombosis. This is one possibility. But you did mention a very important point about enhancing lesions. Could you ever think of any enhancing lesion in CT which perhaps might suggest the cause of increased blood pressure apart from cerebral venous sinus thrombosis?
Yeah, tuberculosis, for example.
Yes.
If the patient is immunocompromised, for example, also toxoplasmosis, primary CNS lymphoma, all this kind of mass, meningioma.
Chronic meningitis, yeah, bro. The meninges might enhance.
Yes, enhancement in the meninges. Yes.
Will anyone be courageous enough to do lumbar puncture on this patient for CSF examination without imaging?
No.
We will hear somebody else. Maybe somebody courageous want to do. If you are in a rural area and you don't have CT scan, will you do lumbar puncture?
No, Prof.
Why? Why not?
Because sometimes the clinical signs of hyperreflexia and weakness, this might not appear
She
in
has no signs.
examination.
This patient has no focal sign apart from possible left sixth nerve palsy, which could be explained as false localizing sign. So what are the focal signs in this patient?
No focal sign.
Okay, so my question to you, you are saying, because if you are stuck in rural area and you think this patient has resistant intracranial pressure, but no focal signs, and even the sixth nerve or even the oculomotor could be also false localizing sign, will you do therapeutic lumbar puncture in this patient? Leave alone diagnosis because you might not have a laboratory even. Will you do that?
No, Prof. Lano. Sometimes some patients CBT might deteriorate after lumbar puncture.
Okay, and maybe also some other
yes.
patients might improve after lumbar puncture.
Yes.
Yeah.
Yes.
Yes. Yes. And sometimes supratentorial lesion might not cause a clinical deficit, and the patient will cool after you do lumbar puncture.
But if you are in a rural area and you think this is a young female and this is false localizing sign and she has gained weight and whatever, and you think most likely this is IIH, and her vision starts to deteriorate and she has no focal signs, what are you going to do? Are you going to wait forever?
You teach us not to do lumbar puncture for
I'm not
papilloma
asking.
because
I'm not asking theoretical. You are in rural area. This patient is obese, for example, a obese patient, papilledema, a right sixth nerve palsy, no other focal signs, and she has increasing headache to the extent that she could not. She's 10 out of 10, severe headache with clear features of intracranial pressure, and you don't have laboratory, no CT scan, whatever. Are you going to do lumbar puncture on this patient? Yes or no? And if you say no, we listen to you. If you say yes, we would like to see who will be, brave enough to do it. Any ideas? We work in resource limited environment sometimes. Okay, I'll give you my answer. If I work in a rural area and I don't have anything and I think her vision is endangered and there are no focal signs and the most likely diagnosis is IIH, I will do a lumbar puncture on this patient because that might save her vision. Because if you leave the vision, will be lost irreversibly. And you also counsel the patient and counsel the relatives of the patient. Say, I don't have CT, I don't have laboratory, I am visiting my family here, and I came across this patient. I am trained in neurology. I don't think I should do it unless I have imaging, but this is very far away. Nearest hospital is 5 hours, and it is expensive to have CT with angio or CT with contrast. If we leave her, she will lose her vision permanently. Will you allow me to do a lumbar puncture with the risk that she might deteriorate, or I just leave her go blind, or even go in coning spontaneously?
I think, Sheikh, what you have suggested is extremely important because myself and Professor Victor Patterson, we did a study on idiopathic intracranial hypertension, seeing quite a number of patients. And some of those patients have come from quite far. And by the time they presented, 5 of them, they got blind because they lost the macular vision. And the cause was IIH are not treated.
And the best treatment is to do a lumbar puncture.
The best treatment is to do LP. So LP with salvage her vision. And even if you are thinking of meningitis, and even if you are thinking of subarachnoid. But I think
what I assumed, Ammar, sometimes you don't have a laboratory even to test for cells or for protein, whatever. So what we do the lumbar puncture, and in two clean tubes, we put CSF and we leave it standing for 24 hours. We call it the clotting test. The CSF, it has very high protein. It will make mesh-like, spider mesh-like if it has very high protein. In rural areas, people used to do this long time ago when they don't have facilities to do protein level or cell count or whatever. So if you are stuck and you are in an environment where you have to take decision, I will do lumbar puncture. I will keep some of the CSF. Even if I don't have refrigerator or whatever, I just put on 2 tubes and see. It's called, it come like gel, you know, it gels out. I
And
still
I think
remember
that
seeing patients with TB meningitis. After lumbar puncture, the patient got a lot of relief of pain, and then the following day, it developed this mesh. Patient started on antituberculous therapy empirically. So this is rare, but sometimes in our environment, you have to take serious decision, even if you don't have facilities, because the outcome of leaving the patient, young patient, is permanent loss of vision. And you have
I
your
think
own
also,
reasoning, you can do that.
I think one of the simple tests you do, if you are anticipating that this patient might become blind after IIS or increased blood pressure, you do the visual field test. It's a very useful test. You do the visual field test. If you have constriction in the center, this means that the macula will be in danger. And immediately, you do it by the frontational method. You front the patient and you do it by the what we call the frontational method.
Confrontational.
Yes, or confrontational method, because we have no facilities for proper visual field testing. So you do the confrontational methods and you look for central constriction. And if you detect central constriction in the patient with IIH, you will be in a position to anticipate that this patient perhaps might lose her vision. And exactly this is the case. And this test, in fact, has been, we have done it. Our Professor Victor has got a strong belief in doing the visual field in patients with IIH. It is as important as looking for papilledema. You can do it to assess the patients, and even you can do it for follow-up of patients. Dr. Aad, if you can proceed now.
Okay, thank you. So let's see her admission CT scan, and people can comment following that. This is just plain CT scan following the routine blood tests. So anyone want to comment?
There is rise of dural connection.
And in contrast, axial CT scan, not well centralized, showing slit like the normal brain parenchyma. There is no obvious ischemic or hemorrhagic insult. There is no clear space-occupied lesion, no clear mass, and there is slit-like ventricles, especially in the frontal horn. But also I'm seeing the basal stair on the continuous stair does not appear, as if that there is some sort of edema. The brainstem, the discrepancy at this area. There is no ambient stair, no interbronchial stair. If the patient that have tight brain or have edema. But there is no obvious pathology clear, no feature of hydrocephalus.
I can see right subdural collection with mass effect and compression to the ventricle. The ventricles are compressed, and there is right subdural collection. It seems that it is chronic because it is septated.
Mahmoud, can you elaborate on this right frontoparietal, whatever you mentioned? What do you think is this in contrast to the CSF, and what do you think is the content of it? And is there anything else there?
There is calcifications also.
There is what?
And the fluid is
There is what?
calcification.
Why you say calcification? Why?
I can see
In the CT,
calcification.
before you should say hyperdense object. You don't say calcification because it could be something else.
Yeah.
Okay, be careful about the terminology, Mahmoud.
Okay.
So
And
there's
the
hyperdense.
fluid-
Okay, first of all, describe the fluid, location of the fluid, and the possible content. Then tell me about the other thing you are seeing there.
Yeah. The content of the fluid, it is it's not similar to the CSF. A little turbid fluid most likely might be pus emphysema.
Maybe pus. Pus will
Yeah.
appear denser than more grayish than CSF or more darker than the CSF.
I think more gray.
Okay, so will you change your mind now? You remember, Mahmoud, we said when you were working with me, when you approach anything, describe, say hyperdense, hypodense in CT scan, and in MRI, hypointense, hyperintense. Okay?
Yes.
And as the intensity are contrasting to the parenchyma of the brain.
Yes.
If it is CSF, like so Hounsfield, you know what I'm talking about. So air is 0, bone is 100. You can always, by visually looking at the CT scan, you can suggest what sort. Is it soft tissue? Is it hard tissue? Is it fluid? Is it air? You can. So will you apply that knowledge, Mahmoud, to this, what you are seeing now? So is this fluid? Is this air? Is this pus? Is this mass? What?
Most likely this is a thick fluid.
Okay. And you said also there's something hyper intense. Where is it and what do you think? Describe it and what do you think? What is it?
It is in the
Where is it?
frontal area
Which
attached to the
side?
bone.
Which side?
To the bone side.
Okay. Atif, please go on and stop when I tell you. Okay, go on, go. Stop, Atif,
Yes.
stop. Stop, Atif. Okay. Oh, Atif, stop. Atif, Atif, stop. Go back. You can hold the cursor, yeah. Okay. Okay, stop there. Stop there. Oh, stop. Okay. What is this? Mahmoud.
Yes, this might be this hyperintense lesion.
Okay, hyperintense. We said also, Mahmoud, again, I repeat the rule. If you see any lesion, you say the intensity for the location. The intensity, is it homogeneous or not? Is it surrounded by edema or not? Is it exerting mass effect or not? And then if you give contrast, which is not the case here, then is it enhancing or not? The 6 features you remember, Mahmoud, will help you to pinpoint the differential. So apply. I'm repeating this for the benefit of others who did not go through the mill of SOBA. So we drilled these people, So where is it?
It's in the right frontal lobe.
Okay, right frontal area. We don't know the lobe. Right frontal area. Okay, one. Is it hyperintense or hypointense or isointense?
Hyperintense.
Okay. Is it attached to the bone or not attached to the bone? Is it separate from the bone? Is it within the parenchyma or outside the parenchyma? What we call intraaxial or extraaxial?
Extraaxial attached to the bone.
Okay. And the base is towards the parenchyma or the base towards the skull?
The base towards the skull.
Is there any edema around it?
Because there is fluid in front of it, I cannot say there
Okay.
is edema.
So is it exerting? Is it space occupying? Is it taking space? It's taking some space?
Yes.
Is it homogeneous or not? Is it like the bone of the
Heterogeneous.
skull, homogeneous or non-homogeneous? The answer is I cannot tell from this cut. You remember, Mahmoud, if you are given this, say from one cut, I cannot judge. I would like to see coronal views. I would like to see other views to judge. But most likely it is homogeneous or non-homogeneous. So that's how you answer. Okay, I will let you off the hook, Mahmoud. معلش. I just want to bring you to the good days of Soba. يا أخي. Go on.
So it could be acute and chronic hemorrhage, subdural hematoma. With this hyperintense lesion might be acute blood on top of chronic subdural hematoma. Or
So it could be
might
acute or chronic.
abnormal-
Acute or chronic, you mean? Why it is so localized? Why is so localized?
The other thing might be meningioma. Small
Okay.
meningioma.
So that could be incidental calcified lesion, which could be meningioma, or more reasonably in relation to this Kenyan lady, this could be a calcified what?
Worm.
Calcified tuberculoma, ya Mahmoud.
Tuberculoma. Okay.
Is there any mass effect from these lesions or not? Is it compressing the right side or not?
Yes, it compressed the right side.
Yeah.
The ventricle appears less.
Okay. So Nizar, I go back to what Nizar said. There is no evidence of retinal failure. There is no. Nizar, I think you should change your mind now. Will you change your mind, Nizar?
Actually, Professor Sheikh, the CT is not centralized, but now there is obvious mass effect on the right lateral ventricle. Yes, it is hypertensive area.
No centralized is not a good reason for me. I will not accept it because you don't judge from. Look at the nasal. We know that the right eye is apparent, so the patient is tilted to her right side during the CT scan. Also, a rule you see, even if there is tilting, but that's not an excuse to miss these two abnormalities, and not to miss also there is some pressure on the right side.
Yes, there is mass effect on the lateral ventricle.
So you will change your mind. Okay.
Yes, there is the right subdural cortex.
I will let you off the hook, Nizam. Do you see something linear also, as Mahmoud said, there is something linear on the far front? It could be acute bleed on chronic subdural hematoma.
Obviously, this lesion is most likely attached to the bone. It's heterogeneous, but there's no obvious bleeding. It's most likely hypodense area. Most likely.
Apart from this, do you see anything else on this CT?
At the base cistern, Professor Sheikh, and at the area of the midbrain, there is no any spaces.
What do we call this? This is called peri-quadrigeminal cistern. It's blocked.
Yeah.
What does it indicate?
Yes, there's edema and there's some sort of maybe herniation, impending herniation.
Not necessarily. It can be feature of raised intracranial pressure. And this is, intracranial pressure could be supratentorial raised intracranial pressure while the infratentorial compartment is normal, or it could be global raised intracranial pressure, or it could be only raised pressure in the posterior fossa. You also, people used to say raised intracranial pressure. Raised intracranial pressure is the big term. Is it supratentorial? Is it global? Is just posterior fossa? When you see blockage of the periquadrigeminal cistern, it means that it is like global raised. And then you look at the fourth ventricle. If the fourth ventricle is there, so it's communicating. Okay? So we can see the fourth ventricle here.
Yes.
Okay? So it's not hydrocephalus. It is not hydrocephalus.
Yeah.
And the aqueduct is patent. You assume, even if this is the axial view, you assume it is patent because the lateral ventricles and the fourth ventricle, you can see them easily. So there is no blockage to cause ballooning of the third ventricle and of the lateral ventricle. And the fourth ventricle, in patients who are having aqueductal obstruction, usually it gets very small, even it disappears sometimes because there is no much of fluid flowing into it. I think we have taken too much time in this case, but I wish next time when we bring imaging, we should go in the details of how to read the scans. we do CT, then we do MRI, then we do plain X-rays as well, and then we do special imaging techniques, inshallah. Thank you so much. Ammar.
Okay, thanks, Prof. Prof. Ammar, do you want to comment?
Can you ever think of any enhancing pathology apart from what Professor Sheikh has mentioned? Can you see any other enhancing pathology? Perhaps it might be obvious when you proceed to the MRI. Atif, Dr. Atif?
Yes.
You can proceed to the MRI.
Okay.
Because
Okay.
Yes.
So this is the axial T2 clear view of her MRI.
Now things have become more obvious. Who would like to comment?
Adif, can you show the other sequences? T1 and DWI.
It's coming, yeah? It's coming. Shall we go to the next sequence?
Pause. Will you pause here? Pause here. Let us go because it is. We are already late. We are already late.
Yes.
Ammar, I think we will just allow 5 minutes more for this case because we have Mahmoud as well and other audience who are external, we don't want to keep them long.
Okay. Atif, now you can comment on the findings, and if somebody would like to add more, he will be more than welcome. Yes, Atif. Dr. Atif.
Okay, so the key finding, I think, of this MRI, it confirmed the right-sided extra axial fluid collection is consistent with chronic subdural hematoma, which, as we have seen, it was hyperintense on T2 flare, crescent shape like tracking along the right hemisphere. There was some mass effect with some sulcal effacement. And there was also some restriction on the DWI, confirmed on the ADC map. And SWI sequence is not showing any hemorrhagic areas, hemorrhagic or microbleeds. So shall we go to the next?
Yes.
So this is the sagittal, just to show. Any views so far?
Any contrast?
Brachiomeningeal enhancement on the right.
Yes.
As if there is enhancing meninges in this right side.
Yes, brachiomeningeal enhancement on the right side. Most likely this is infection in the EMA. This patient needs the surgeon to be aware.
Apart from meningeal enhancement, can you see any other areas which are enhancing apart from the meninges? Okay, so on these findings, on these imaging findings, what is the most likely diagnosis before Dr. Atif can offer more information?
Right subdural emphysema, Prof.
If in Bahima, it have to restrict in the DWI and enhance, I think.
Oh.
Any more suggestions? Dr. Atif, would you like to give more clues? Would you like to offer more clues without
Let me
mentioning
suggest,
the
Marwan.
yes?
Let me suggest, could it be unilateral intracranial hypotension?
Why have you suggested so?
Because in unilateral intracranial hypotension, the meninges will enhance. It might also auto-enhance on T1, and there will no restriction of the diffusion to the collection. It will be CSF, normal CSF.
And in this case, what causes decreases the intracranial pressure?
Might be fistula or something in the right hemisphere.
Fistula coming from where? Is there any sign of fistula? And because if you suggest something, you have to explain it.
I think the patient also had multiple small strokes on the left frontal and left parietal.
Why have you suggested so?
Can we see the MRA and MRB if possible?
Without it, proceed.
Okay, before that, can I just 2 comments? Yeah, Nizar, he showed you an MRI with contrast. You don't need to go for MR venogram, but you can see the superior side sinus is quite patent. You can see the lateral sinuses. Sinuses are clear, and you see that there is midline shift. Nobody commented on this. There is midline shift towards the left side. The meninges will enhance whenever there is pulling or there is increased vascularity. So low intracranial pressure could be due to leak of CSF within the spinal area, not necessarily you can see in the brain. So the brain is pulled down and the subdural hygromas will be secondary to this. So I support Mahmoud for the possibility that this could be well feature of CSF leak, not in the brain, but CSF leak maybe dorsal area or in the lower cervical area, which are the common site of spontaneous dehiscence of the meninges, and they cause spontaneous intracranial hypotension rather than. I could see also a slight sagging of the brain downwards. If you ask me how I do this, if you go to the posterior fossa, look around the midbrain and the pons. If you go down, Adem, if you go down towards the posterior fossa. If you go slightly down, you can see that the slight descent of the brain. Okay, stop here. Stop. Okay, that's it. Look at the cisterns here, ya shabab. Look at the cistern. Even the meninges around this are also enhancing. And you keep the periquadrigeminal space is already completely obliterated. And if you look at the sagittal view, if you show sagittal view, maybe also see a bit of sagging of the brain. I'm just imagining, but this is not conclusive feature, but it's something which makes you think, is this really residual or low intracranial pressure rather than anything. So because there's no history of trauma, it's just severe headache, this can happen with idiopathic intracranial hypotension rather than hypertension. The meninges will enhance because the pulling and there will be increased vascularity. And the hygromas are actually CSF, which is causing what look like subdural hematoma in somebody who's young. In an elderly, I'll say maybe this long-standing subdural hematoma. And there were no focal neurological signs, although there's midline shift. I'm just, look here. Do you have a sagittal view? Sagittal view.
I'm sorry, I haven't brought it here.
Fine. So from this one, I could say there's a slight descent of the brain within the aperture in the tentorium cerebelli. I'm just suggesting. Okay.
Okay, thank you.
And if you can wrap up this case, because we have taken 1 hour in this very tough case.
Okay, so as you said, this is post-contrast T1 weighted MRI brain, which which is suggested there is linear enhancement along the leptomeninges, showing feature of leptomeningitis. There is also abnormal parenchymal enhancement with some midline shift. So in general, now we reach a conclusion that what is the differential diagnosis of pachymeningeal enhancement. This was the summary from the neuroradiologist here. There is hypertrophic pachymeningitis on the right with sphenoid sinusitis, and there is a small foci of diffusion restriction, as Nazar said, on the left side, possibly ischemic. Otherwise, normal intracranial arterial appearance. So this slide showed the possible common etiologies of hypertrophic pachymeningitis, which we can classify as idiopathic, cranial or spinal pachymeningitis. And idiopathic, we said idiopathic when we take brain biopsy and came negative for the other causes. Or as Prof. Oshek said, intracranial hypotension, which is spontaneous or post-spinal fluid drainage. And there is a wide range of infections like Lyme, syphilis, tuberculosis, fungal infections, cysticercosis, HTLV, malignant external necrotizing otitis due to Pseudomonas. And then the autoimmune vasculitic causes like GPA, Wegener, and rheumatoid sarcoidosis, Behçet, Sjogren, and temporal arteritis, and malignancy, either dural carcinomatosis or metastatic disease in adjacent skull bone or lymphoma, and finally meningioma. So open to the audience, what further investigation would you suggest before we reach the final diagnosis?
I would like to see the CSF analysis.
Okay, basic investigation before the CSF analysis for the causes we mentioned.
Complete blood count, ESR, C-reactive protein,
yeah,
and peripheral blood picture, and
yeah. So yeah. So for the sake of the time, yeah, as mentioned here, the routine investigation, infection marker, CRP, ASR, which will reflect inflammation, vasculitis marker, and then the autoimmune screening, including all of these, and then S for sarcoidosis. And one of the common causes of pachymeningitis is IgG4 related disease, so we need to do IgG4 level. And other infections like HIV, syphilis, serology, and then TB quantiferon, and lastly, fungal antigen. You mentioned lumbar punctures. As you remember earlier, this patient was having some midline shift, so the lumbar puncture was not safe, but if it is safe, we can consider it. Checking the opening pressure, CSF cell count with differential, and CSF protein, glucose, CSF TB PCR, acid fast bacillisme, and CSF cytology, and IgG4 index and oligoclonal band, and CSF fungal stain if clinically indicated. So we have done CT cap for this lady, as we was not able to do lumbar puncture, and the routine bloods we mentioned. You know, it takes time to the result to come back. So to rule out any possibility of malignancy as one of the causes or other related causes, we did CT full body, which showed prominent hilar lymphadenopathy and left supraclavicular mediastinal, hilar, and para-aortic and retroperitoneal lesion. And along with that, there was multiple isointense hypodense liver lesions. So quickly, what does the audience think of these findings?
It could be tuberculosis, it could be lymphoma, and it could be secondaries
Okay.
from the liver.
Okay, agree. She's having left ventricular Virchow node and mediastinal, hilar, and para-aortic and retroperitoneal. Hello. So the other differential was possibility, along with the infection, possibility of metastasis actually, because there is multiple liver lesions. So we spoke about the source. The next logical step would be to take a biopsy from accessible node like the supraclavicular or mediastinal, or we PET CT for metabolic activity and guidance, and others like LDH, IgG4, and S, HIV, TB quantiferon. And this patient needs hemato-oncology referral because of the liver lesions and this multiple lymph node found. We spoke about the differential. So neuro-oncology MDT, there was discussion about this patient. I suggest that it could be lymphoma or metastatic adenocarcinoma as the top differential. So the biopsy of the supraclavicular node was taken, core biopsy. The indication, the reason we mentioned earlier, malignancy versus infections. So the result of the biopsy came back showing metastatic adenocarcinoma, which was unexpected, and the TB PCR was negative. Any thought here?
Atif, if you just because you know this Virchow's node is a very famous story. The professor was giving a talk about stomach cancer and said it could be whatever, and very prominently sometimes supraclavicular lymph nodes. And during the lecture, he touched his supraclavicular fossa to find a huge mass in his own supraclavicular fossa, and he was Professor Virchow. So he's a called Virchow lymph node, very characteristic of adenocarcinoma of the stomach. If the story is correct, still, but at that time we don't have sophisticated investigations like today. So probably this is an adenocarcinoma, which is highly malignant, most likely.
Thank you very much. Yes. We have done CT abdomen pelvis, which showed a very rare type of stomach cancer called linitis plastica, with some adrenal and hepatic metastasis, and the OGD, esophagogastrodiagnoscopy, confirmed gastric adenocarcinoma and the final diagnosis is stage 4 gastric adenocarcinoma, and the final decision was best supportive management for this lady. So metastatic gastric adenocarcinoma, CNS involvement with vacuum meningitis and subdural collection, systemic involvement with liver, lymph nodes, and adrenal metastasis. And it is open for the floor for more discussion.
We should give you a big upload, Wallah, Atif.
Yeah. Atif, you would like to ask them about the association of this, and is there any association of this subdural collection you did mention?
Association with what, Prof?
You may, because the story the patient presented with this subdural collection. You mentioned in the story the patients, and it's shown in the CT, the MRI, the subdural collection. What is the association between what you have mentioned? I just want to alert the audience.
Yeah, so this indicates how extensive was this type of disease, which metastasized to the meninges and to the brain, along with the other organs, which lead to this subdural fluid collection.
So I would love if you mentioned saying carcinomatous meningitis complicating linitis plastica. You know, they call it linitis plastica. It just goes like زي الجلد المدبوغ, like the tanned hide of animals. يعني thick and at the same time it's a bit soft. And usually it is like undifferentiated gastric cancer, if I remember good from my good old years.
Yeah, as you said, this is laser bottle appearance. Yeah.
يا جماعة بالعربي أنا, if you allow me, I'll say this is like السعن. تعرف السعن? This is the animal hide which we use to take water or to cool water in. Linitis plastica. It becomes like that feeling. If anyone, like a Bedouin man like me, I know the feeling of this leather when it has water inside. So that's how it will feel during surgery or when you see or a specimen. Well, this is excellent case, Atif. So the subdural collection is actually oozing secondary to the metastasis, which we saw in the right frontal area. So it's carcinomatous meningitis complicating linitis plastica. I hope you are writing up this case, Yahi.
It's very interesting. Thank you very much, Atif. I think you did extremely well. It's not an easy case, but I think we passed through this journey of so many pathologies, so many symptomatologies, so many history points, signs, etc., until we reach finally the conclusion. It was not an easy job, but I think Atif has done his best to make it.
Thank you very much.
Professor Oshek.
Yes.
And Dr. Mahmoud. Mahmoud also has got two interesting cases, but I don't think he's going to have time. Can we allow Mahmoud to present his two cases next time? Because
yes, it's already got very late and people are getting. But this case deserves, Mahmoud, I hope you accept Professor Ammar's suggestion, because it is just like a very interesting, tough case, and we learned also from it. We all learned from it. So can we, because we have like 10 minutes more, we can ask the audience to comment or to give ideas about this case, and we keep the secrets of Mahmoud's fantastic cases for next month. Is that okay?
Next time, Mahmoud, the whole floor will be yours. We will not allow anybody to present. Only you are going to present your two cases.
And you can add your third case if you like. So it will be Mahmoud's show next month. Because we had a lot of technical problems today, you know. The meeting goes in off, and then it did not stabilize. And at last, alhamdulillah, we managed to get everything on. So we would like to hear also comments, you know, from people in the UK, and also we have Iman left already. Snesh is not here. Sarah Misbah Sadiq is here. Professor Sarah Misbah, you are most welcome. Sarah Misbah, we'd like to hear from you, ya akhi, after all this time, ya akhi. Sarah Misbah.
السلام عليكم.
عليكم السلام والرحمة والإكرام.
مرحبا بكم، ومعليش أنا هتكلم بالعربي يا عاطف.
No way. You have to speak in English, because we have people who don't speak Arabic with us.
يعني if you can remind us, Atif, again, the complaint was headache. Am I right? It was just headache. Am I right? To end up in all this story, going up and down the body and ending up with an adenocarcinoma of the stomach. يعني in a million years, I would never have thought about that. I was just thought it was a low blood pressure, low CSF pressure type of headache causing this enhancement. And that's it. I never thought that we're going to go all this journey. But anyway, thank you very much. Thank you very much for the lovely presentation. بعدين thank you Sheikh وعمار thank you Mahmoud for the contribution and the lady doctor. معليش, I was up and down trains and things like that, so I wasn't able to follow. But what an ending. Thank you, Atif, for the lovely presentation.
Who else would like to comment, يا جماعة? So we have 7 minutes. Roa from Newcastle.
Yeah, thank you, Atif. It was very good case, very excellent, very detailed. I think the reflection and the lesson learned from this case, history. So the presentation initially was suggested for postural problem, the headaches, the tinnitus, and then examination findings, nothing was localizing. And then MRI, I think, was very typical for the low pressure features. I think the pituitary was enlarged. This wasn't reporting. And the sinuses were engorged. So it would be also very important to look for other causes of other radiological features of intracranial hypotensions. For me, I was like thinking, why from MRI brain we went for CT tap? So for me, when I saw the MRI brain, I felt the next step would be getting MRI spine, just look for a dural lake. And then if it was negative, I would go for CT myelogram rather than going for CT tap. But I went out thinking the history, you mentioned the weight loss, another feature. So this is sometimes you make, because apart from the weight loss, I won't do a CT tap for these presentations because you try to look for the spinal cause before, try to look for other systemic disease, for example, like sarcoid or IgG4 or the other differential you mentioned in the list. So this is all about the history, because if the weight loss was not flagged, I don't think you will go for the CT tap. So if we put the things together, postural symptoms, look for the red flags, and then after that you eventually would reach the diagnosis. Maybe also in these cases, for example, if this case wasn't having advanced malignancy and she was like for post-supportive management, and if we assume this is actually either a spontaneous intracranial hypotension, would be useful to reflect on the management, how these patients manage. So CT myelogram is something good to mention, and then the follow-up parameter of improvement, patch, if we assume this is actually was a spontaneous intracranial hypotension rather than there was other causes. But very nice case. I wasn't thinking about we're going into the malignancy pathway, to be honest. But thank you so much.
Okay, 4 minutes more.
Bro, for Shajjah, I am surprising for Atif. If the patient didn't have anything in the systemic examination, for example, organomegaly, lymphadenopathy in the exam, because the history is very important in neuro and the examination is very important in the general medicine.
In London, they don't examine the abdomen. Neurologists even don't use the stethoscopes in London.
No, I understand, but I think if I don't know, maybe if they may found the organomegaly, hepatomegaly, for example, a large lymph node, Verschau, they may see it. But it is very interesting case, very good presentation, Atif, and you are still Real Madrid. Real Madrid.
It's a big fun.
This is the most important thing in the presentation.
As I have 2 comments here, Atif, if you listen to me, all right? The first is you have very well prepared this case, and you did very good rehearsal. But to increase attractiveness to your presentation, don't try to give too much information. Okay, that's number 1. And also, don't respond one-to-one when you are, like presenting in international meeting. Don't respond one-to-one. Make note of the questions Okay, and when you respond to people, it will be very nice and professional to respond by the name. Professor Sarah Misbah, you asked about so. Mahmoud, you asked about so. Yeah, Dr. Rania, you mentioned this is so. It will be more interactive and more, like appreciative for people. And also by mentioning the name of those who asked before, you introduce them to the audience as well. And after the meeting, most likely they will start to know each other. So it's an indirect way of networking, also of to talk to people with their names. Excellent presentation, very good, well thought of. I myself, believe me, I never thought this will be malignancy, as Sarah Misbah said. Complete surprise. And as Roa said, I went very much towards idiopathic intracranial hypotension because looking at the other features I mentioned and what also Roa has reiterated. So the other thing, not everybody coming from Africa has tuberculosis. We have been taken from the outset to infections. We were all thinking in direction of infection because he just mentioned she's originally from Kenya. This is another also thing which we should not put in mind infection, but don't be limited to infection. The other diseases or rarities can happen. And Mahmoud, I'm sure you remember our patient who has this IgG for who came with the polycranial neuritis. If you remember, I presented this patient in the World Congress. So her tongue, half of her tongue became wasted, and she has fever and headache. And we were really puzzled because all tests were normal. Then CT with contrast showed pachymeningitis. And then we did IgG4, and then she had plasma exchange, and then we put her on steroids. Actually, her tongue regrew in 6 months' time, and she's a completely different person. So we have been taken on by infection. So don't be taken on by infection. And also this technique of presentation. I also remember one of the shortcomings of our training is we don't teach people on presentation skills. This is a good forum. I think you are the star of the day. You did perfectly well. And I will leave it for Professor Ammar to conclude because the time is over. Thank you so much. Very happy to see this flourishing forum. Thank you all. Thank you very much.
Thank you all. Thank you very much. I endorse all what people have said. I think Atif has done an excellent job. It is a very comprehensive and nice presentation. And I think we look forward for Mahmoud next time. I am sure Mahmoud will be the star of the show next time. Thank you very much all. Have a nice time. Sleep well. Wassalamu alaikum.
Assalamu alaikum. Have a nice night. Impressively good. See you next month. Bye-bye for everybody.
Bye.
All right. All the best. Ma'as salama.